morning. Today we'll talk about blood gases and pH measurement. So regarding blood gases or acid-base balance, there are two organs that are important in the regulation of or in the maintenance of acid-base balance. So you have your lungs and kidneys. So first, regarding the lungs is responsible for the excretion of carbon dioxide. Okay, so excretion of carbon dioxide. And regarding carbon dioxide and pH for acid-base balance, remember this one, pH is equal to bicarbonate over CO2. Okay, so your lungs is responsible for the excretion or for the control of CO2 level. Okay, and regarding the retention and excretion of CO2, it has rapid and it is very sensitive, or it is rapid and very sensitive adjustment in the effect of retention and excretion of CO2. You have rapid and very sensitive adjustment in blood pH. Okay, so regarding CO2, this is inversely proportional to pH. Increase CO2, decrease pH, meaning acidic, and decrease CO2 effect have increase in pH. Now, regarding the buffering system in our body, you have the bicarbonate, okay, bicarbonate carbonic acid buffering system. Okay, so this is our conjugate base and this is our weak acid. Now, the ratio, okay, of the bicarbonate and carbonic acid should be 20:1 to get a pH of, or to have a pH of 7.40. 7.40 is the ideal blood pH. Okay, so nasa sa middle between 7.35 and 7.45. So the ideal pH is 7.40. Okay, so to maintain 7.40, you have a ratio of 20 bicarbonate and H2CO3 have 1. Okay. Next, slow or non-removal of CO2. The effect, you have respiratory acidosis. Slow removal, meaning you have increased CO2 in your system. Increased CO2 in your system, the effect is acidosis. And that is respiratory acidosis because the cause is decrease or slow elimination or removal of CO2. Okay. Next is for rapid or fast elimination of CO2. The condition, you have respiratory alkalosis. So fast elimination, the effect is you have decrease in the level of CO2 in your system. So decrease CO2, effect, you have increase in pH. That's why there is alkalosis and it is respiratory. Okay, respiratory because the problem is in the regulation of CO2. Next organ, you have the kidneys. So for the kidneys, the function of kidneys is the excretion of acids, okay, generation and excretion of bicarbonate, and the excretion of H plus. Okay, so the conditions that are associated with increase in bicarbonate, you have IV infusion of lactate, acetate, and bicarbonate. Okay, IV infusion of lactate, acetate, and bicarbonate. Then decreased bicarbonate concentration, you have the use of diuretics, reduce reabsorption. Okay, reduce reabsorption of bicarbonate. Okay, for diuretics, you have increased excretion of bicarbonate and chronic nephritis, another cause of decrease in bicarbonate. Okay, so if the level of bicarbonate is below 25 millimoles per liter, your kidneys will start the reabsorption process of bicarbonate. And if it is greater than 25, then the kidneys will start excreting, okay, will start the excretion of the excess bicarbonate. Okay, so that's the function of kidneys in the regulation of acid-base balance. Okay, next is you have the blood buffers. So the blood buffer, the major buffering system in our body, it's the bicarbonate carbonic acid buffering system. The next is you have plasma proteins, hemoglobin, and inorganic phosphate. Carbonic acid is a weak acid because it does not completely dissociate into H plus and bicarbonate. And regarding carbonic acid, that is the major buffering system. Uh, we're not using strong acid as buffer, because if you're going to use strong acid as buffer, then there will be uh, the alteration in your pH is kind of frequent there's frequent alteration in your blood pH. So para mas makontrol ang pH, you need to use weak acid, because for weak acid, mas difficult or mas less ang rate of dissociation is not that high or frequent ang dissociation, or sakto ba ang frequent? Basta dili kay siya mo dissociate. Okay? That's for um, weak acid. So weak acid is the weak acid that we're using as a buffer. You have your carbonic acid. Okay? Plasma proteins have buffering capacity through charges on their surfaces. And hemoglobin is an effective buffer because it can offload its oxygen and combine with CO2. Okay. Next is the Henderson-Hasselbalch equation. So for Henderson-Hasselbalch equation, you have pH is equal to the pKa, or dissociation constant, plus log. Then this is your conjugate base over weak acid. So the conjugate base is bicarbonate and the weak acid is um, carbonic acid. And we're using weak acid as part of our buffering system because of the um, slow dissociation. Okay? So mas difficult, or no, mas lisod pag dissociate sa H plus and bicarbonate. So it will not alter immediately the blood pH. Whereas if you're using strong acid, then it can cause abrupt alteration, okay, to your blood pH. Okay. Next are the parameters in the assessment of acid-base balance. So first parameter, you have pH. So the reference range is 7.35 to 7.45. So below 7.35, that is acidosis. Greater than 7.45, that is alkalosis. The optimum, it's 7.40. And to get the optimum blood pH, you need to have a ratio of 20:1 between bicarbonate and carbonic acid. Then the venous blood, if we're going to compare the pH between venous and arterial blood, venous blood is zero point zero 0.03 pH unit lower than arterial blood, and it's because of chloride isohydric shift, or the chloride shift. So meaning of chloride shift, you have the uh, exchange of chloride, so chloride from outside to inside, and bicarbonate from inside to outside. Okay, so venous blood is lower, zero point zero 0.03 lower, okay, than arterial blood because of the chloride shift. Okay, decrease of 0.015 pH unit per Celsius above 37. Okay, so if you have fever, for example, 38 degrees Celsius, so per Celsius above 37, you have a decrease of 0.015, okay, in your blood pH. So the effect of fever is you have acidosis. Okay, it's because of the increase in the rate of metabolism. So increased rate of metabolism, you have increase in the concentration of metabolites. And usually the substances, or ang mga byproducts of metabolism, you have acidic substances. That's why you have decrease in blood pH if there is increase in body temperature. Okay. Next parameter, you have PCO2. So normal, it's 35 to 45 mmHg. Less than 35, that is alkalosis. Greater than 45, that is acidosis. And it is an index of efficient gas exchange. So delete that one. Index of efficient gas exchange, and not a measure of CO2 concentration in blood. So lungs regulate pH through retention and elimination of CO2. So our lungs is important in the regulation of blood pH. So ang imong lungs, if there's a problem with the retention or elimination of CO2, that can cause alteration in blood pH, because CO2, that is inversely proportional to your blood pH. Next is increasing ratio of heparin to blood can cause marked artifactal rise in measured PCO2 by 12 to 15%. So regarding heparin, heparin is the anticoagulant of choice for arterial blood gas analysis. Now, regarding heparin, if you overuse heparin or you increase the volume of heparin, that can also cause false increase in your PCO2 level. Okay. Another cause of increased PCO2, we have the use of illicit drugs like barbiturates and morphine, and also alcoholism. Okay. Next is bicarbonate. So for bicarbonate, the reference range is 21 to 28 milliequivalent per liter. Less than 21, that is metabolic acidosis. Greater than 28, that is, less than 21, that's metabolic acidosis. Greater than 28, that's metabolic alkalosis. So bicarbonate, that's directly proportional to blood pH. Okay, and this one is controlled by your kidneys. Okay. Next is PO2. So for PO2, for adequate oxygenation, you have 81 to 100. For hypoxemia, mild hypoxemia, 61 to 80. Moderate is 41 to 60. And severe, you have 40 mmHg or less. Okay. And it reflects the availability of the gas in blood, but not its content. Changes more rapidly than PCO2 or pH, and is 60 to 70% lower in venous blood after oxygen is released in the capillary tissue. So if we're going to compare PO2 between the lungs, no, between venous and arterial blood, the venous blood has 60 to 70% lower in PO2 level than your arterial blood. It's because of the release of oxygen to the capillary tissues. So, cause of low PO2, you have myocardial infarction, interstitial pneumonia, severe congestive heart failure. So, healthy person living at higher altitudes will show lower ranges of arterial PO2 because of the naturally lower partial pressure of oxygen in the atmosphere, and so in the inspired air. Okay, so next you have the four basic abnormal states. So the first abnormal state, you have metabolic acidosis. So for metabolic acidosis, the cause, it's bicarbonate deficiency or the decrease in bicarbonate. Okay, so example of causes of metabolic acidosis, you have diabetic ketoacidosis, lactic acidosis, so example in alcoholism. Okay, so regarding alcoholism and lactic acidosis, remember alcohol is toxic to your liver, and if there's a problem with your liver, there is damage that can cause decreased gluconeogenesis. Okay, and for us to clear or eliminate lactate, we need to, or our liver must perform gluconeogenesis. So the problem with alcoholism, you have decreased gluconeogenesis. Okay. Another is renal failure. Okay. Renal failure, another cause of metabolic acidosis. Okay. You have buildup of acid, then diarrhea, you have excretion of bicarbonate. Okay. In diabetic ketoacidosis, you are producing ketones. Ketones are acidic. Then in diarrhea, you have increased bicarbonate loss. And in metabolic acidosis, since there is acidosis, you have efflux of potassium. So in acidosis, you have increased H plus, okay, in your plasma. So one of the compensation of your body is to transfer H plus from extra to intra, and in exchange, to maintain electron neutrality, you have to transfer K plus from intra to extra. So that's why you have efflux of potassium. That's why one of the electrolyte imbalance present in metabolic acidosis, you have hyperkalemia. Okay. Then next, compensation of metabolic acidosis, you have breathing rate. Breathing rate increases to lower PCO2, meaning if there's acidosis, the compensation is hyperventilation. So the purpose of hyperventilation is to eliminate or to have fast elimination of CO2. So fast elimination of CO2 effect, you have lower CO2 level. And remember, pH is equal to bicarbonate over CO2. Okay? So decrease in CO2 effect, you have increase in pH. So that's how the body compensate when there is metabolic acidosis. Okay? So after compensation, you have low bicarbonate, low PCO2 level, and the pH is less than 7.4. But it is within the reference range. Okay? Kaya ba it's acidosis, no? So before full compensation, the pH, the blood pH is less than 7.35. But after full compensation, or if it is fully compensated, then the pH should be within the reference range but below 7.4. Okay? That's for metabolic acidosis. Next, the maximal compensation is completed within 12 to 24 hours. Okay? So that's for metabolic acidosis. And if PCO2 drops 1 to 1.3 mmHg per MEQ, PCO2 drops 1 to 1.3 mmHg per MEQ liter fall in bicarbonate. Okay, so if there is a decrease, okay, of 1 MEQ per liter in bicarbonate, the PCO2 will also drop by 1 to 1.3 mmHg. Okay, so that is the ratio for the compensation. And for electrolyte imbalance, I have hyperkalemia. It's due to the efflux of potassium, and hyperchloremia. So there is hyperchloremia because of the deficiency in bicarbonate. Okay, to maintain electron neutrality, since there is bicarbonate deficiency, you need to increase chloride concentration. So hyperchloremia. Next is metabolic alkalosis. So in metabolic alkalosis, the cause is bicarbonate excess. Okay, so bicarbonate excess. Okay, and common cause of metabolic alkalosis is vomiting. Okay, vomiting. Okay, you have the common cause of metabolic alkalosis. Okay, another cause of metabolic alkalosis is the use of diuretics. Okay, that can cause metabolic alkalosis. And the compensation for metabolic alkalosis, since there is alkalosis, the compensation should be hypoventilation, not hyper, but hypoventilation. Okay, so the purpose of hypoventilation is to reduce the elimination of CO2. Okay, to increase the concentration of CO2. Okay, so increase CO2, decrease pH. Diba the problem is alkalosis? So to compensate that one, you need to lower the pH by increasing the CO2 level. And to increase CO2 level, you need to do, or your body needs to perform hypoventilation. Next is after compensation, you have high bicarbonate, high PCO2, and a pH greater than 7.4. Okay, greater than 7.4, but not greater than 7.45 because it's fully compensated. But for partially compensated and uncompensated, the pH is greater than 7.45. Next, the maximal compensation is completed within 12 to 24 hours. The compensation is least effective in metabolic alkalosis because of hypoxemia. Okay, because hypoxemia is inevitable consequence of hypoventilation. Okay, so it's difficult to compensate metabolic alkalosis because in metabolic alkalosis the compensation is hypoventilation, And if there's hypoventilation, the consequence of that is hypoxemia. Okay. Next, for every 10 MEQ per liter rise in bicarbonate, the PCO2 rises by 6 mmHg. And opposite to your metabolic acidosis, the electrolyte imbalance for metabolic alkalosis, you have hypokalemia and hypochloremia. Okay. Next is respiratory acidosis. So for respiratory acidosis, it's due to excessive carbon dioxide accumulation. Okay. So cause of carbon dioxide accumulation, first is COPD, chronic obstructive pulmonary disease. Okay, so COPD is one of the disease associated with smoking. Okay, so cigarette smoking that can cause COPD. Secondhand smoke that can also cause COPD. Okay, I'm not sure with vaping, but I think vaping that can also cause COPD. Okay, long-term effect of vaping. Another cause of carbon dioxide accumulation, you have myasthenia gravis, and myasthenia gravis is an autoimmune disease. Okay, so your body is producing autoantibodies that attack the nerve that is responsible for your breathing. Okay, so you have problem with your breathing because of the autoantibodies that attack the nerve responsible for breathing. Okay, next is CNS disease. Another is drug overdose. Example, morphine, barbiturate, and opiates. Another cause is pneumonia. Okay, so that's for respiratory acidosis. Another cause of respiratory acidosis, you have botulism. And for the compensation, kidneys retain bicarbonate. Okay, so acidosis, decrease pH. So to increase that one, you need to retain more of bicarbonate. And the organ responsible for the retention of bicarbonate, it is your kidneys. Next, after compensation, the pH is less than 7.4, but it is within the reference range. And the PCO2 level is high, and also the bicarbonate. High bicarbonate, this is the compensation, and this is the cause of respiratory acidosis. Maximal compensation requires 5 days, but is 90% complete in 3 days. And bicarbonate rises 1 MEQ per liter for each 10 mmHg rise in PCO2. Okay, so that's for respiratory acidosis. Next is respiratory alkalosis. So for respiratory alkalosis, it's due to excessive carbon dioxide loss, so rapid breathing or hyperventilation. So causes of hyperventilation, so example, you have anxiety, okay, severe pain, aspirin overdosage or overdose, hepatic cirrhosis, gram-negative sepsis, and progesterone drugs. Okay, so cause of respiratory alkalosis is hyperventilation. For respiratory acidosis, it's hypoventilation. So blood pH tends to be extremely high when respiratory alkalosis is caused by psychogenic stimulation of the respiratory center, because the condition is usually super acute and therefore there is no time for compensation. Now, regarding the compensation of your respiratory alkalosis, you have decreased reabsorption of bicarbonate. Okay, so the pH after full compensation, you have pH greater than 7.4, but it is within the reference range na ha. So within the limit nga 7.45, but greater than 7.4. Low PCO2, this is the cause of respiratory alkalosis, and low bicarbonate level, this is the compensation. Okay, so compensation is completed within 2 to 3 days. Among the 4 types of acid-base disorders, compensation is most effective in respiratory alkalosis. So bicarbonate falls 2 MEQ per liter for each 10 mmHg fall in PCO2. Okay, so that is for respiratory alkalosis. So for respiratory alkalosis, you have the cause is hyperventilation, and the compensation is to decrease the absorption of bicarbonate. Next, mixed acid-base disorders. So for acid-base disorders, it refers to a clinical condition in which two or more primary acid-base disorders coexist. They generally present with one obvious disturbance with what appears to be an inappropriate compensation. Okay, so let's talk about sa katong four metabolic acids, four acid-base disorders. So for example, respiratory acidosis. So the cause of respiratory acidosis is the increase in CO2. Okay, so remember pH is equal to bicarbonate over CO2. So you have increased CO2, decrease pH because it's inversely proportional. And the compensation for respiratory acidosis is to increase bicarbonate level, increase reabsorption of bicarbonate to increase the blood pH. So regarding the level of CO2 and bicarbonate in respiratory acidosis, you have increased bicarbonate, increased CO2. Okay? Now, in respiratory alkalosis, the cause of the disturbance is you have low CO2 level. Okay? So low CO2 level effect you have increase in pH, and to bring the pH back to normal, you need to eliminate bicarbonate or to decrease the reabsorption of bicarbonate, okay, to lower the pH. So if naka-observe mo, the arrows kay isa lang direction, one direction. For respiratory acidosis, you have increase, increase. For respiratory alkalosis is decrease, decrease. Now, for example, if the pH is decrease, the bicarbonate is increase, and the CO2 is decreased, this one is an example of mixed acid-base disorder. So you have inappropriate compensation because for appropriate compensation, if the cause is decrease in CO2, the compensation should be decrease in bicarbonate. If the cause is increase in CO2, the compensation is increase in bicarbonate. Now for this one, you have decrease CO2, increase bicarbonate. So this one is inappropriate compensation. So this is the example of mixed acid-base disorder. So when two disorders influence the blood pH in opposite directions, the blood pH will be determined by the dominant disorder. Okay, so that's for mixed acid-base disorder. Okay, so next is you have the measurement of pH, PCO2, and O2. So blood gas analyzers use electrodes as sensing devices to measure PO2, PCO2, and pH. So for PO2 measurement, it's based on amperometric uh, principle. So the amount of current flow is an indication of the oxygen present. And since we're using electrode for the measurement of blood gases, the name of the electrode for PO2 is the Clark electrode. Okay, Clark electrode. Okay, so remember for sodium and potassium, sodium is glass aluminum silicate electrode. For potassium, it's valinomycin gel electrode. For O2, it's Clark electrode. And sources of error, you have buildup of protein material near or buildup of protein material in the membrane or in the electrode that can cause false decrease in PO2 level. Next is bacterial contamination that can also cause false decrease in PO2 because of the oxygen consumption, okay, by the bacteria. And another cause of error, you have incorrect calibration. Okay, low PO2 levels may be seen with high white blood cell count. So example, in patients with leukemia, you need to process the sample immediately to avoid false decrease in PO2. It's because of the increase in white blood cell. So increase white blood cell, increase consumption, oxygen consumption by the white blood cell. So the effect, you have low PO2 level. Okay. Next is in the measurement of oxygen. You can also use transcutaneous electrode. So it is placed directly on the skin, and measurement depends on oxygen diffusing from the capillary bed through the tissue to the electrode. Most commonly used with neonates and infants, and it is non-invasive. Okay, so skin thickness and tissue perfusion with arterial blood can significantly affect the results. So the factors that can affect, okay, the O2 measurement, you have the thickness of the skin and also the perfusion, tissue perfusion, okay, or the amount of blood nga ginasupply to different tissues. Next is for the measurement of PCO2 and pH. So for PCO2 and pH, you're using potentiometric. So there's a change in the change in voltage indicates the activity of each analyte. So same with PO2, you're going to use electrode. So for pH electrode, the name of that electrode is glass electrode. And you need the glass electrode and the reference electrode. So for the reference electrode, you're going to use silver chloride electrode and calomel electrode. Okay, so that's for pH. So you need two electrodes, the glass electrode that will be in contact with the specimen, and the reference electrode, you have your silver chloride electrode that will be in contact with the standard. Then next is for PCO2, you have your Severing-House electrode. Okay, so Severing-House electrode, that's for PCO2. Okay, so those are the names of the electrodes used in blood gas analysis and pH measurement. Next is quality assurance. So only personnel who have experience with the drawing equipment and have knowledge of the possible sources of error should draw samples for pH and blood gas analysis. So meaning only physicians and nurses in the pulmonary unit are allowed to collect samples for blood gas analysis. Okay. Next is because collection may be painful and result in patient hyperventilation, which lowers the PCO2 level. The effect of hyperventilation is decreased PCO2, and if there's a decrease in PCO2, it increases the blood pH. So the ability to reassure the patient is essential. So you need to reassure the patient or to assure the patient that the procedure is not that painful. Okay. And the choice or the site for arterial blood collection, you have your radial artery, brachial, femoral, or the temporal artery. And it is usually customary within an institution depending on the predominant patient population. So it depends on, regarding the collection site, it depends on the predominant patient population. So for example, if bata, then usually they will use radial artery. Okay, but for old, usually they will use femoral. Okay, femoral artery. So radial artery, it is small, but it is easily accessible, and it is the most commonly used site. Hematoma is relatively low, okay, because it's more of a superficial artery compared to the brachial artery. Brachial artery is deep, okay? Dili siya superficial, so it's difficult to apply pressure after blood collection. So inadequate blood supply to the hand may suggest the need to select another site. So in order to identify or to determine whether the hand has a collateral blood supply, sakto ba ang term, you need to perform modified Allen test. The purpose of modified Allen test is to check the capacity of the ulnar artery to supply blood. If there is an injury to the radial artery or during or sa tabalik ko na ko regarding modified Allen test, the purpose of modified Allen test is to determine whether the ulnar artery can supply blood to your hand during sa time nga there is injury to the radial artery. Okay, so if the result is positive, then you can perform radial artery or you can use radial artery for arterial blood collection. But if the result is negative, then you need to choose another site, okay, for arterial blood collection. Next is brachial artery, preferred for larger volumes, more difficult to puncture due to deeper location between muscles and connective tissue. So brachial, it's near the uh, basilic vein. Okay, that's why basilic vein is the third option. Okay, kaya diba the first option is the median cubital, the next is the cephalic, and the third is basilic. So one of the reasons nga nung basilic is the third option, it's because it's near to the brachial artery. Okay, difficult to palpate in obese patients, and hematoma is more common. Hematoma is more common uh, because the artery is deep or has deeper location. Okay, deeper location. So it's difficult to apply pressure after blood collection. And it's not commonly used in infants and children. Okay. Next, femoral artery. So femoral artery, it's a large vessel, it's superficial, and it's located in the groin. It is easily palpated and punctured. Generally, this is the last site selected in clinical practice. And it has poor collateral circulation to the leg. So usually, it's the only, or murabag siya ang main artery that supplies blood to your leg. Dili siya pareha sa imong hand nga you have ulnar and radial. Okay? So, next, increased chance of infection of the site is if this is if not thoroughly cleansed, presence of pubic hair makes a septic technique more difficult. Okay? In newborn infants, the hip joint and femoral vein and nerve lie so close to the artery that injury to these structures is a hazard which may contraindicate this procedure. So for newborn, it's not good to use femoral artery as the collection site for arterial blood collection. Okay, that can cause damage sa femoral vein and the nerve. Okay, there's a possibility nga may mahit ay mong nerve. Okay. By contrast, puncture of the femoral artery in older infants and children is relatively easy and safe. Okay. Next, the use of venous samples for pH and blood gas studies is not recommended. So for blood gas analysis, the preferred sample is arterial blood. Okay. Recommended collection devices for arterial blood samples include glass and plastic syringes. But if you're going to use glass, then you can after collection, you can place the syringe in a slurry of ice water because glass is impermeable to gases that can alter PCO2 and pH values over time. If plastic syringe is used, it is recommended that the sample not be iced and be analyzed within 20 minutes. Okay? The reason, it's because of ang plastic syringes man god, dili siya same with glass nga impermeable. So if you place that one in a slurry of ice water, there's a possibility that the PCO2 and PO2 levels will be altered. Okay? So for glass, you can place that one in a slurry of ice water, but for plastic, uh, avoid placing the sample in a slurry of ice water. Okay? But that sample should be analyzed within 20 minutes. Both dry and liquid heparin are acceptable anticoagulants, but liquid heparin, there's a possibility that it can cause dilution. Okay, so the appropriate anticoagulant, it is heparin. Slowly filling of the syringe may be caused by a mismatch of syringe and needle size. Okay, slow filling of the syringe. So in the filling of syringe for arterial blood collection, you don't need to pull the plunger. Okay? Ang maka-fill sa syringe, it's the pressure, the arterial pressure. Okay? So, ang plunger is mo, saka lang siya iyaha because of the arterial pressure. Okay? Now, if there's slow filling of the syringe, the possible cause of that one is the mismatch of the syringe and the needle size. Maybe you're using a small needle. The standard is 21. Okay. Next, too small needle, it could produce bubbles as well as hemolysis. And maintenance of anaerobic environment is critical to correct results. Okay. The blood in the syringe must be mixed with the heparin anticoagulant to prevent clots from forming and being injected or aspirated into blood gas analyzers. Okay. Transport time of the sample should be minimal. Immersing the specimen in ice water slurry prevents changes in PCO2, pH, and PO2 in glass syringe. So you don't need to place the specimen in a slurry of ice water if you're using a plastic syringe. Okay. So next is the quality control for blood gas analysis. So you need to use commercial liquid control materials for this one, and you need to run 3 levels of control, meaning you have acidosis, normal, and alkalosis. Okay, so three control materials, and you need to run these three control materials every 8 hours. So meaning every shift. So you have morning shift, afternoon, and night or nocturnal noc shift. So run the three materials in the morning shift, also in the afternoon, and also in the night shift during night shift. Okay. Then another way of performing quality control for blood gas analysis is the delta check. Okay, so you're comparing the current result with the past result. Okay. Next, specimen consideration. So on standing, pH and PO2 decrease, okay, and PCO2 increase. So on standing, pH and PO2 and PCO2 are affected. So prolonged standing of sample that can cause false decrease in pH and PO2. So you have consumption of oxygen and pH, the decrease in pH due to the increase in PCO2. Okay. So blood samples should be chilled to prevent oxygen consumption by the RBC and release of acidic metabolites, thereby altering the pH. So the purpose of placing the sample in a slurry of ice water is to avoid or to prevent oxygen consumption or to prevent the false decrease in oxygen and also the false decrease in pH. Okay. Glycolysis results to decrease blood pH. Okay. And that's another reason why you need to place a sample in a slurry of ice water. Excess heparin causes downward shifting of blood pH. So the increase in heparin or excessive heparin that can cause false decrease in your blood pH. And it's the most common pre-analytical error. Regarding heparin, heparin is the preferred anticoagulant or the ideal anticoagulant for blood gas analysis. But between liquid and uh, liquid and uh, uh, liquid and dry heparin, okay, dry the end term. The ideal is the dry heparin because for liquid heparin, there's a possibility that it can cause dilution to your sample. Okay, so low temperatures cause increased oxygen solubility in blood and left shift in the oxyhemoglobin curve, resulting in more oxygen combining with hemoglobin. Factors affecting blood gases and pH measurement, you have temperature. So this is the most important factor. So for each degree of fever in the patient, PO2 will fall 7% and PCO2 will rise 3%. Okay, so the increase in PCO2 that can cause decrease in pH. Okay, so elevated plasma protein concentration that can also cause problem with your PO2 measurement that can cause a false decrease in your PO2. So PO2 test is affected by buildup of proteins on the surface of the membrane or the electrode. Okay. The next, bacterial contamination within the measuring chamber, if present, will consume oxygen and cause low value of PO2. So you have consumption of oxygen by bacteria. Okay. So improper transport of the blood specimen. So when blood samples are not transported on ice, the PO2 changes. So you have decreased PO2. Then you have increased PCO2 and decrease in pH. Okay. Samples should be kept at room temperature and analyzed immediately after blood collection. Okay, now Remember, if you're using glass syringe, then you need to place a sample in a slurry of ice water. But if you're using plastic syringe, then uh, maintain lang ang room temperature. You don't need to place that one in a slurry of ice water. Okay? Next, blood gas results should be back to the physician, preferably within 10 minutes after draw to obtain maximum benefit from them. Okay? So regarding arterial blood gas analysis, it is a stat test. Okay? So you need to have the result within 10 minutes after collection. Okay? So that's for blood gas analysis. And sir, anong stat man usually ang ABG? It's because mag-ABG lang ka once ang patient or usually ang ABG mangod gina-perform patients uh, in patients nga naa sa critical care unit or intensive care unit. Okay? So ang sample or ang result sa imong nga specimen or result sa imong testing is important sa pag-determine sa condition sa patient nga in the critical care unit. That's why all ABG or usually ABG analysis, arterial blood gas analysis, kay stat na siya nga test. Okay? So that's all regarding blood gas analysis and pH measurement. Thank you.